Hi there. Welcome to Newsnight. I am Ladi Akeredoluale. Thanks for your company today. As the most prominent gateway, as well as being the commercial capital of Nigeria, Lagos is in a unique position to gauge as well as react to many of the most critical health challenges the country faces. From the feared resurgence of the COVID-19 pandemic to increased cases of monkeypox, Lassa fever, and other endemic diseases, the state usually gets to come face to face with them first. In fact, the World Health Organization, WHO, has just declared monkeypox a global health emergency with the highest alert level, as more than 16,000 cases have now been identified in more than 75 countries, including Nigeria. My guest on the program, however, believes that a robust mechanism of response, including the continuing upscaling of facilities as well as personnel, is being undertaken, and that rather than a reactive policy, a careful balance of lives and livelihoods is the way to go in dealing with these situations. Newsnight talks to a professor of internal medicine, hematology and environmental health, the current commissioner for health in Lagos State, Abayomi. Honorable Commissioner, thank you for your time. It's nice to see you.
Thank you. It's a pleasure.
I guess when people see you, they're going to wonder what it is this time. And I think I should start from, it's been in many of the media outlets that our numbers are rising again. And there are those who have said, depending on whose figures, but the ones that I saw are being referred to as NCDC figures. There's been a more than 300% rise month on month from June to July. And that has some people worried, particularly because they say outside of Lagos, there are very few, if any, other states testing. And so whatever numbers we get are not an accurate depiction of what's really going on. Do you agree with this? And is there cause to, should I use the word, be alarmed?
So we haven't dismantled our COVID testing infrastructure. The only thing that changed was because we had come out of the fourth wave, the federal government decided to drop the mandatory PCR testing for travelers, which was one of our key indicators of what's going on in the state. We've found out over time that the points at which we trigger a wave coincides with certain times of the year, characterized by high travel for Christmas and for the summer vacation. So we always had a heads up intelligence because people traveling in had to test, and those that were positive, we picked it up early, and then obviously there'll be a slight lag between imported cases and community transmission. But we've done away with that because we're trying to normalize COVID, not make it one of those things that just keeps people, anchored down and, slowing down the economy. So obviously, the virus is being imported because there's COVID all over the world, various levels of wave 5 and wave 6. Lagosians and Nigerians are very mobile people, so we anticipate that we're going to see some increased activity around this time, especially with all the kids coming back for vacation. And kids are usually the ones that are socializing abroad and mixing and catching various viruses and bringing them home. So what we've picked up in our setup of both public and private laboratories is a low-level activity increasing gradually. We don't know whether that's going to trigger a full-blown fifth wave. It coincides with what federal government are also observing from their various testing sites. We give our data to Abuja, and Abuja synthesizes and manages the data and publishes it to the general populace. But we also have anecdotal evidence that there is increased activity in the community. People are using a lot of rapid tests, which is not captured in our data systems, but we hear about it and we see people. But one of the key markers of significant activity is admission into our care centers. So both our public and our private COVID care centers, or isolation centers as you know them. We have really excess capacity at Yaba in IDH, which we've built over the past 4 years with a lot of other infrastructure. So we maintain that, and we're on ready standby all the time. We're monitoring the activity at Yaba, and it's almost zero. We also have in parallel the home-based care system, which means that if you're tested positive, immediately your name and your number and your contact details goes to Eco Telemed. Eco Telemed contacts you to find out how you're doing and to see if we can manage you at home or whether we need to admit you because your symptoms are moderate to critical. So far of the positive cases that we've been picking up, which is a low-grade activity, our contact with the clients shows that most of them are mild, asymptomatic or moderate and very well suited to managing at home. In the background, we're doing a lot of activity preparing. You know, we're always trying to be one step ahead of this virus. So we've got a lot of elaborate equipment in Yaba. We've recently acquired a sequencer, a genomic sequencer. So all our positive cases, we're subjecting them to genetic analysis to see which variant is coming into Lagos. Are we going to get any surprises? Are we generating any mutants ourselves? We obviously have all our laboratory infrastructure in place. We have all our isolation centers in place. We have a huge capacity to admit. And we are still partnering with the private sector to make sure that if we do get a massive surge of cases, that both the private sector testing and both the private sector care centers are intact and can absorb, because some people, we can absorb a lot as government, but some people prefer to go to private, you know, so we want to make that option available. But by and large, we're trying to routinize COVID now as a way of life, you know, so that even if there is another subsequent wave, and what we're seeing is community transmission, but people are not getting very sick, which means one of two things. It means either the virus has downgraded itself or we've achieved a significant amount of herd immunity in Lagos and Nigeria. And herd immunity is acquired either from natural infection or from vaccines. Right. Now, we've had 4 waves, which means that most Lagosians have seen this virus at least once, sometimes twice or 3 times. So everybody in Lagos, by and large, and by virtue of the heavy population density in Lagos, whenever we've had a wave, it spreads through community very quickly. So I imagine that most Lagosians have been infected at one point in time through the 4 waves, if not once, multiple times. A significant number, well, although low compared to international numbers, are being vaccinated, and that process is going on. So when you add natural infection to the gradually increasing numbers of people being vaccinated, you have a community resistance to COVID. So it sort of adds up that we're seeing infections in community, but we're not seeing sick people, and people are not dying, which means that we have some kind of pushback to this virus. And so it is now transforming into something like the common cold or COVID or the flu, you know, where you get sick, you stay at home for a few days. It doesn't stop life in Lagos. It doesn't stop the economy. What we learned from the 4 waves is that sometimes your exaggerated response can be worse than the offending problem, you know. So we don't want to stop livelihoods in Lagos, break down, you know, security, cause chaos, you know, and that kind of thing. So COVID is there. Yes, it's all over the world, but I think the world is learning to live with COVID. And we in Lagos have started to live with COVID quite a while ago, and we're trying to continue that.
Now, a lot of people are familiar with COVID, and we're just getting settled into it, as you said, normalizing it, if you like.
Yes.
Then other things started coming up, and an awareness problem was again generated. Let me give you an example. When monkeypox arrived in Europe, and there were accusations back and forth as to where it came to Europe from, there were, amongst the index cases, they said one was from Nigeria. And that again sent shockwaves back here to say, oh no, please, not again.
Yes.
Before some of the authorities here then said, look, we were dealing with monkeypox for quite a while. So this isn't new. It's not like COVID. So there isn't really reason or need to panic.
Yes.
In Nigeria, as far as you know, is the awareness level for this quite high enough? How does one know, for example, that someone has monkeypox? We can now talk about COVID because quite a lot of people know that. There's been a massive awareness campaign and all that. But in the case of monkeypox, if it's been around for that long, how come it's remained under the radar, even as other things have taken prominence, even including the likes of Lassa fever?
Yes. So monkeypox, we are not unfamiliar with monkeypox. It sort of comes, a couple of cases come every year, and we're ready for it. We know how to diagnose it. We know how to manage it. It's a relatively benign infection that presents itself with chickenpox-like vesicles on your face and on your palms. It's not very contagious, but that is the West African variant. There is another variant that comes from East Africa, from Central Africa, around the Congo. It's a slightly different variant. It's a bit more contagious and it's a bit more aggressive. And we have, through the literature and our colleagues in that part of Africa, we have the information that more people are succumbing to monkeypox in this Central Africa region. And so, but the variant that is circulating abroad through genetic analysis seems to be the West African variant, which is the one that we see in Nigeria. Which is why when you see the cases are rising exponentially in Europe, it's not accompanied by very large fatalities. In fact, very few fatalities compared to the Central African variant. So thank God it's not the Central African variant that's causing the problem. So the question is, why are we seeing so many cases abroad? Not in Nigeria. We have only seen about 7 this year in Lagos, and we've sensitized our general hospitals and our PHCs. They all know about it. We've had conferences. We've talked to them. If you see cases that look like this, don't hold on to them. Refer them to Yaba, because that's where we'll isolate them, make sure they don't transmit it to other members of the community. We manage them. There is as yet no treatment for it, so it's just care and counseling and normal inpatient management. But what we are gathering from the European and other parts of the world is that this spread of monkeypox is associated with certain lifestyles, and they're attributing it to communities of homosexuals, men having sex with men, and sexual networks. Which is in keeping with the nature of this virus, because it is transmitted by very intimate contact. Just me and you sitting here. If you had monkeypox and I, was sitting next to you, it would be very difficult for you to give me monkeypox, even if you sneezed or coughed. So it relies on very close contact. Either you're sleeping in the same bed or you're very intimate with somebody. So we're not surprised that this is the nature of the escalation abroad. And it doesn't mean that it's a different variant, even though we're working on analyzing the genetics of what we have here in Lagos and what's coming from abroad. It doesn't necessarily mean we're dealing with a new variant, but there is some suggestion that the variant that's circulating in Europe and the rest of the world, even though it originates in West Africa, has certain new mutations. So it might be that lifestyles in the developed part of the world where these networks are operating and where this transmission is high is giving this virus the opportunity to change somewhat. And maybe that requires some elucidation. As far as we're concerned here in Lagos, it's not bothering us. We are cognizant of it. We're ready. Our diagnostic capabilities are on par. We are setting up sequencing for it. Of course, we have our isolation facilities already standby. All our doctors know about it. So we're just ready in case we see a rise in cases, either of our indigenous viruses or it coming back from Europe by the usual air transportation. If it's a slightly different variation on our own, well, we'll pick it up when it does come.
This tends to bring to prominence the importance of community health. because many of these things are going to happen at the communities.
Correct.
And then they're going to be detected and then managed, even from what you've said so far.
Correct.
That's usually the procedure. So I guess the next thing is to take a look at that community health status.
Yes.
At our various community levels, the primary healthcare centers and so on. A lot of emphasis is placed on our tertiary health centers because those are the ones who gain prominence, they're the ones who have, shall we say, the fat budgets, if you like. But the community health centers, which is where most people will ever get to,
Yes.
seem to be less prominent. Correct. How important are they, especially in an era where we're dealing with a series of pandemics?
So the emphasis of this government has been to rebuild the primary platform, primary healthcare platform. As you rightly said, 80% of people will go to a primary healthcare facility, whether it's a government or a private sector. That's the first port of call, other than our traditional medicine and alternative practitioners, which I'll come to later because we can't ignore them because they're part of society and people use them. So what we've done is to pay attention to those two grassroots healthcare service delivery systems, the primary healthcare and the traditional and complementary and alternative medicine, because that's what our people use. So traditionally, in terms of manpower, infrastructure, governance, very weak, but we've been strengthening it over time. Each successive government has been building on the primary healthcare structure to strengthen it because that's the base of the pyramid. The secondary and the tertiary builds upon a strong primary healthcare. So what we've done here is we have a strategic master plan in this dispensation, and in that master plan we've looked at the key areas that we need to rejig, refine, and redefine. And PHCs and traditional and complementary are one of those areas. So we've done an unpacking of that system, and we've looked at the infrastructure, we've looked at the funding, we've looked at the human resources. So when we start with infrastructure, the general tendency was that people convert houses to clinics. So they're not purpose-built. And a non-purpose-built primary healthcare facility is a disaster because if you are not sick when you went in, you will be sick when you go in. That's where you catch COVID if you had hypertension, something like that. So Mr. Governor said, go away and develop a master blueprint for medical infrastructure transformation. So we started with two things. We started with the PHCs and the general hospitals, and we've developed this very amazing blueprint architecture for PHCs using international designers plus our own indigenous designers to get a new way of building medical facilities fit for purpose. So in the PHCs, we have this sort of open, ventilated, very translucent, very attention to infection prevention control, able to repurpose under pandemic circumstances. We finished our blueprint and we're just about to start rolling out new buildings of this nature. So they are fit for purpose. They're designed for patient flow, staff flow. They're designed to reduce infection contraction during a consultation. They're very low energy because you see what's happening to our petrol and our diesel. The prices are skyrocketing. We can't have these medical infrastructures that cost an arm and a leg to maintain. So low maintenance, we've worked with our agency for maintenance to design very low energy, low maintenance, a well aerated, designed to suit the environment and the climate in which we live, with some cultural context built into it as well.
Right.
The same thing we've done with the general hospitals. But coming back to your point, so that's the first thing to do, is to build infrastructure that's fit for purpose. Then we need to increase our manpower and our training within those facilities, which we're doing. And then the third thing is to find a way of the governance structure. Before, we didn't have a strong agency or the board that governed the activities of the primary healthcare platform. So we've done that, we've put that in place, a very strong board. And the governance structure is the board, the local government authority, health authority, and the ward authority. So now all three structures are in place. Now we have to work with the local government, the state government, and the federal government to make sure that the PHCs are the first port of call and that patients are not bypassing the primary health care and going to overcrowd the general hospitals and the tertiary facilities. And most competent primary health care practitioners can deal with 80 to 90% of anybody's complaints. So that's where we're putting all that emphasis into PHCs, building new PHCs, getting new staff engaged, defining a demand structure in terms of who pays for health, which is why we're introducing the insurance scheme. And it's a blended finance approach. There's government funding, we're increasing government budget allocation to health. We're engaging donors to make sure that donors are coming in to look at our exciting strategic plan for the next 2 or 3 years. And of course, we're bringing in insurance. Of course, people still want to pay out of pocket for certain things, but if you buy our insurance now, we're trying to make sure that when you buy insurance, you're actually buying something that's worth it. So when you go to a PHC, whether it's a government or a private facility, and both can be empaneled, that you're actually getting value for money.
That brings me to the key issue which you raised in answer as you were ending the answer to the last question when you talked about funding and the role of insurance. I did allude to it when I was starting, when I talked about the fact that, a lot of funding goes to tertiary because that's where it seems as if it's more glamorous. The ailments there are of more importance and all of that. But as a whole, the health sector funding is, I don't need for you to tell me this, we had the experience when COVID arrived unannounced. It's very inadequate.
Yes.
And even if government was to put 100% of its funding into health, there will still be gaps.
Correct.
So which brings the issue of other funding mechanisms, one of which is this insurance you mentioned. How useful is it? Because many people start off with a trust deficit of insurance in Nigeria. And therefore, when you talk about health insurance, people say, well, when I'm sick, I'll deal with that when I'm actually sick. It's a mental, it's also a psychological thing. How are you dealing with that?
So that's a very interesting question, Ladi, and it's really the crux of the matter. We don't come from an insurance culture. People, unless you force them, when you drive a car, you can't drive a car without insurance. So you're forced to buy insurance. Otherwise, you drive around without insurance and just pray that you don't have an accident, But when you do have an accident, then you thank God you had insurance, right? So the same applies to health, If you leave health as insurance for health as voluntary, most people won't buy insurance. So Lagos has been pushing back on the National Health Insurance protocol because we believe that it needs to be mandatory. And now President Buhari just signed the National Health Insurance Authority bill into effect, which are one of the key areas there is that it makes the purchase of health insurance at the state level mandatory, which means that it's not an option. As you walk around in Lagos, breathing Lagos air, eating Lagos food, and doing business in Lagos, you must carry Lagos State Health Insurance in your pocket. So now it's become mandatory. We're going to domesticate that in Lagos. We tried to make it mandatory before, but the fact that it wasn't mandatory at federal weakened our argument. But now that federal have made this a mandatory component of insurance, it's very easy for us to domesticate that. Now, once it becomes mandatory, then a lot more people will be compelled to acquiring this insurance. Now, we can't stop there because if you buy insurance and you go to the point of sale, which is the clinic, which is where you're going to receive care, and you have a bad experience, you're not going to come back. You're going to say, I'm going to abandon this, I'm going to try and default and just go to where I know I'm going to get good health and pay out of pocket, right? So what we're doing, it's a catch-22 as people are patronizing the health insurance scheme, we as government are putting a lot of emphasis into where people are going to go to receive this treatment and their first port of call, which ties in very nicely with the question you asked about the PHCs. So that's where we need to really build and diminish the trust deficit. So you walk into one of our accredited PHCs, whether it's public or private, and we have LASHMA, which is that agency that manages it. You won't be accredited as a care deliverer until you've met certain standards. And part of that standard is hospitality and medical etiquette. How are you received when you get there? Are you go and sit down there, or hello, good afternoon, sir, how can we help you? And then you produce your card and you get your treatment and you have a good experience, because what you pay for insurance, 8,500 naira for a year of bouquet of health services free of charge. You know that you can go to a hospital for one time and come away with a bill of 50,000 naira for
that 8.5 in some hospitals wouldn't even cover the card.
Exactly. So, but you see, it's pooled funding, so it's not like that 8,500. You see, other people have bought 8,500 and never used it. So the pooled funding comes together and is beneficial to you, is beneficial to the system. It helps the system improve the infrastructure. Doctors are happier, and allied health professionals are more likely to remain in a system where this kind of demand infrastructure is in place.
The other thing that leads to naturally would be public and private partnership. Yes. As I said when I was asking you the last question, government can put in only so much because it has to attend to other needs.
Correct.
So this is where the private sector has room to act.
Yes.
But you find that because the health sector doesn't appear, in many societies is viewed as a social service. And therefore, when you come into it and you say you're dealing with it as a business, people tend to look at you and they do a double take. But in other climes, that is the way it is done, and that's why their services are of such top-notch quality. Now, getting people to accept that you pay for what you get can be difficult once the mindset indicates that this is a social service, so it's not supposed to make profit. It's just supposed to be a service for which taxpayers' funds are responsible. How do you get to have the private sector join government in such a way that it makes sense for them because they can possibly make money while offering the service, and government can release some of the stress on its neck in terms of providing facilities and funding?
So yes, this is critically important. So as you know, Mr. Governor is increasing the health budget every year as best he can. So it's gone up from 9 to 10 to 11%, as trying to approach 12%, trying to approach that magical 15%. So at the same time, we as government is improving the budgetary allocation to health. We have drawn up our master plan for the 4 years. And when we look at our master plan to convert Lagos into a first-class medical hub, where we're reversing medical tourism, we're reversing brain drain, we're actually attracting people from the rest of Nigeria and from the rest of the sub-region to Lagos as a medical tourism destination. We drew up the master plan, not just in the public service, but how we influence the private sector. And we looked at the budget, and it's way above what budgetary allocation we have. So the first thing we have to do is just make sure we maximize the drawdown and the impact on the budget that's been given to us. After that, we ensure that there are efficiencies in the system and we're plugging all the leaks and the drainages. And then we go into a blended finance strategy, which is where we bring in the private sector. And we did this so well in COVID. We soon realized in the first wave that the numbers of cases that were coming in was way in excess of what government facilities could have managed. So we invited the private sector in, and we remained in control, but we defined the benchmark, we defined the standard, and the private sector initially were a bit scared, but soon there was quite a deluge of interest in both testing and delivery of care and vaccination. So it worked beautifully in COVID, you know, that government-private sector marriage. Sooner or later, as you said, government was able to transfer some of the responsibility to the private sector, and it triggered the economy. You know, people knew that if they went to a private facility, they were going to pay some fees. What we did as government was to make sure that the standard was right, that there was price controlling, you were not charging in excess of what you need to charge, and that we're protecting the public. You know, and once we put those measures in place, and there was good governance, once we put those measures in place, the private sector were very happy to work with government to deliver a service that was life-saving for the entire state. You know, and it, instead of dropping the economy, we generated a COVID-like economy within the private sector that kept things ticking over. So, using that experience, we are now preparing the same kind of strategy in a PPP arrangement through blended financing, whereby we're inviting, after all, 70% of Lagosians seek their care in the private sector. So this is the Ministry of Health. It's a Ministry of Health for health of all Lagosians. It's not just Lagosians going to public facilities. We need to make sure, excuse me, that we're ensuring standards in the private sector, and where possible, we're creating opportunities for the private sector to work with the public sector. When we are giving you volume and outsourcing services to you, then we can dictate prices because it's an economy of scale. Right. So, you know, you're seeing much larger people, but we're managing the cost, right? The standard rises, the clients are happy, there's income generation both in the private sector. We are relieving our budget, we're taking the pressure off our budget. We're able to use that for other things and to develop other facilities in the state. And so everybody's happy. The economy is taking over. People are making a livelihood out of healthcare delivery, and government is feeling relieved, and some of the pressure is taken off. It doesn't mean that we don't keep on increasing our budget. It doesn't mean that we don't keep on setting the standard. It doesn't mean that we don't keep on plugging the holes. It doesn't mean that we don't keep on ensuring that the budget translates into meaningful, impactful programs that increases the standard and the quality of health in the community, as you just asked.
One of the places where you have gaps, obvious gaps, is in terms of the numbers. And when I say numbers, I'm talking about the numbers of personnel. Doctors, nurses, midwives, all this. Because all these areas are not people you can just bring in. They're not like security or admin clerks and so on. I mean, this, in the case of doctors, 7, 8, 10, 12, 15 years, depending on the type of doctor and the level. Nurses, the same thing and so on. So we never have enough, so to speak. And our population is moving exponentially. Where it was last year isn't where it is. I was listening to a very interesting argument a bit earlier to say, look, we've got to somehow slow down the population to allow the facilities catch up. Otherwise, we're going to be running this race permanently. In terms of doctors, nurses, and because you've just established that a lot of the care concern is at the base,
yes,
you also find that most of your colleagues don't want to go to the base. They don't want to go to the rural areas and attend to people. They'd rather remain in Ikeja and Victoria Island and so on. And this is replicated, it's not unique to Lagos, it's right across the country.
correct.
And because they're such professionals of limited quantity, they get to dictate, so you can't really force them. So how do those people at the rural areas get services if the people who are supposed to offer them the services don't want to go in that direction? They want to remain here.
So another one of our strategic initiatives is access to care for people in hard-to-reach areas of Lagos State. And hard-to-reach areas is anywhere like a riverine area where there are no roads, where there's some security issues, or where, if there are roads, you know, the roads are difficult, you know, there's...
To navigate.
So we've launched a access to rural health rural outreach program. And one of the things we've just, if you notice, we launched a water clinic a few weeks ago where we purposely designed a water ambulance which will start to navigate to some of these clinics in water-rine areas.
Yes.
Yeah. So that's a pilot. We're going to see how that goes, and then we're going to start collecting more and more of these water ambulances and water clinics that will take personnel to these areas and also bring patients back who have complications. And then there's, incentives, so we're putting in the hardship incentives. So Lagos is divided into the Ibile zones. And the way we navigate it is that we want X number of specialists and X number of medical personnel per Ibile zone. And some of these Ibile zones comprise some of these hard-to-reach areas. So by definition, when we're allocating medical resources to these 5 locations in Lagos, you automatically will be appointed into one of these hard-to-reach areas. And then we'll define a hardship allowance. And you'll go there and we'll support you. And we're building infrastructure in these hard-to-reach areas. So it's not as if you're going to be going into the bundus and you're under a hut or outside under a palm tree or a coconut tree. No, we're trying to develop the infrastructure. We're trying to incentivize you. We'll do it on a rotational basis. You can come and go. You spend some time there and you come back, and then we'll have, mobility that takes you there, and set up, infrastructure with renewable energy and that kind of thing. So we're very deliberate about reaching these areas. Fortunately for us, nowhere is too rural and too hard to get in Lagos. It's not like, you're going to some of the states in the rest of Nigeria where you have to travel a long distance, and sometimes there are security implications. So for us, it's not too difficult, and most parts of Lagos can be reached somehow. It's just that, as you rightly pointed out, maybe somebody doesn't want to go and spend 3 months there. So we're gradually getting there, and we have a lot of medical personnel in Lagos, despite the impression that there is brain drain in Nigeria. There is brain drain in Nigeria, but most of the brains will drain to Lagos. And then from Lagos, if they don't make it in Lagos,
then they drain out.
Then they bounce out. So that's a big concern to us. And if we've been putting very deliberate things in place. Mr. Governor's had a lot of time for these associations, the medical doctors, the nurses, the allied professionals, to find out what are your grievances, what exactly is the problem, and we've managed to address, there have been strike threats throughout the past 2 years. We've been able to meet with them, sit around the table, and address each and every one of the problems to their satisfaction, and so most of the medical doctors and nurses and allied professionals are, relatively much happier now in Lagos than they were before, as we've managed to address strategically some of the issues that they've complained about. So that's one thing. Brain drain will always happen because people are always wanting to go outside to maybe get a better education or a better postgraduate, or salary is better or whatever. But what we're doing is we have another strategic approach, which is what we call brain gain strategy. So if you're a newly qualified doctor and nurse and you find out that you want to go abroad, so okay, you go abroad, but you're a Lagosian or you're a Nigerian. There are not many Nigerians who are abroad that don't want to come home. If you put the right infrastructure, the right facilities in place, a lot of them will come back. So we allow, in our own hearts, we're saying, oh yes, we've lost so many doctors, but they're still Nigerians, they're still Lagosians. They go abroad, they get 1, 2, 3 specialties, they become extremely sophisticated medical experts, and then what we're doing in Lagos is we're diversifying our medical infrastructure. So we're no longer focusing only on general hospitals. We're now working on a comprehensive cancer facility, a cardiac and renal center. We're building a psychiatric hospital, 500-bed psychiatric hospital, and then a 1,000-bed rehabilitation center. We are developing an infectious disease research institute, and we've got a few others. We want to develop geriatrics. We want to develop spinal and nervous institution. We're now developing a short stay specialist facility at Lagos Island General Hospital, where you can come in for your endoscopy, your arthroscopy, things that you would normally fly out of the country for.
Right.
Now, when you set that up, all these specialties within the system, then our colleagues abroad, doctors, nurses, are saying, hey, there's something to come back home for. These facilities, I don't have to move back to Lagos, but I can come back and spend a month, or come back and spend a weekend, and then eventually people who want to return back home will come and work in facilities with the type of equipment that they are accustomed to working with abroad. Sophisticated equipment and well-built infrastructure, and giving therapies that they are accustomed to giving in sophisticated climes. So that closes the loop. And we're already beginning to see that. As we build these sophisticated facilities, Nigerians are very curious about what's going on. Our colleagues in the diaspora are saying, oh, can we come and be part of this? And they are part of it, and they are coming back. So we see that in the next few years that we're going to have this relatively sophisticated medical environment where our Nigerian doctors, our Lagosians, will come back to in our brain gain strategy. So it's okay for them to leave because they get trained at their expense, Europe's expense, to a very high level, and they come back, and of course they're going to transfer capacity here, and they're going to train our younger ones, and then our younger ones will be less inclined to go abroad.
You're one of them.
Absolutely.
Because a look at your CV reveals that you spent a bulk of your career abroad. Mm-hmm. Top-notch institutions, huge facilities, excelling, and then you came home. I read some of the messages that were said to have been sent to you when you took that decision, like, why? Where are you going? What happened? And all that. And you said, well, I'm going home. I want to see what it is I can contribute. But upon arrival here, it must have been a complete sea change for you. Mm-hmm. Coming from where you were coming here. Not to put too fine a point on it, it was going, the other way around. How did you navigate that, both from a physical and a mental perspective, to find that many of the things you were used to taking for granted, you now had to really work for or do without? Mm-hmm. How much of that did you have to do, and how did you do it?
So it's not the first time I came home. I've tried to come home at least 3 times, and each time you face that frustration that you're talking about, and you're young enough to say, okay, I can't do what I'm trained to do here, let me go back. So you go back, you carry on doing what you're doing abroad, then you try again, you come back, and still the environment is not quite right, and you're not prepared to build a whole institute on your own, without, there's a threshold that's required. But on this occasion, I've been in many parts of the world, as you said, and I just thought, all right, this is time to really go and sit down and navigate whatever the problem is. And I think that the level of medical care was already beginning to rise. We're already experiencing some sophistication in the medical environment. And my predecessor, Dr. Jide Idris, was very instrumental in me coming back and persuading me to fit back into the system. And I worked with him for 4 years before taking on this position, helping the system, build a more robust biosecurity framework, surveillance system, ensuring that we had the right infrastructure in place should we ever come across a biological threat like Ebola. And sure enough, COVID came along, and thank God, Jide Idris had already put those things in place with help from a network of other people like myself, brought in funding, built the right environment for Lagos to be prepared, and it rubs off, it has a domino effect, so you came back, and the if you like, the ground was a bit more fertile for planting seeds that were going to grow into institutions that one can say are of international standard. Being an academic before I became commissioner was also very helpful because it created a very large network for me both in country and across the continent and abroad. So coming into the position of commissioner with the support of many people in Lagos, the political angle was one thing, you know, being a technocrat versus a politician, you know, but you know, you're in a position, you're a policy maker now, you know, so you bring your wealth of experience with you. You know what Nigeria needs, you know what Lagos needs because you've seen it all around the world. So coming in as a policy maker, you're able to bring certain intellectuals with you, to blend them into the system, to have a sort of diffusion. And one thing that I did that was very helpful was setting up a private sector think tank, because there's a lot of expertise, there's a lot of knowledge in the private sector. And that think tank works with the Ministry of Health to infuse these ideas. And we used a lot of this think tanking and strategic formulations to not just respond to COVID, but to respond to all the other myriad of health problems that we have in the state. So gradually, we're raising the bar. Gradually, we're beginning to make Lagos the place to be for advanced medical treatment. But at the same time, making sure that we're looking after the base at the primary level, because it's not all about tertiary academic and tertiary care. Everybody, diabetes, hypertension, malaria, infectious diseases, birth control, neonatal, you know, child nutrition, and we're paying attention to all these things because at the end of the day, we're looking at human capital. You need healthy people healthy children to go to good schools, to get a product that are going to drive the Lagos economy and make Lagos competitive with London, New York, Milan, Japan, China, India. Why not? Somebody described Lagos as the equivalent of the Asian tigers. We've got the right constitution and we've got the right leadership. Under the leadership of Governor Babajide Sanwo-Olu, there's a drive to improve the sector, you know, and we've got great minds in Lagos, both in the civil service and in the private sector. You just need to bring all that together and set the bar, and things just fall into place.
Professor Abayomi, thank you so much.
You're welcome.
Thank you so much.
It's a pleasure, Ladi.
Thank you very much.
Thank you.
That's our program today. We would, of course, like to hear from you on the conversation. Our social media handles are right there on your screen. You can also listen to this and previous episodes of the program via our podcast. Please visit our website, channelstv.com/podcast to get started. I am Ladi Akeredoluale. Goodbye.